I just realized that myself.
Absolutely. Okay, here we go. Welcome to Learn with Longevity in the University of Chicago Medicine. November is Lung Cancer Awareness Month, but for those of us caring for or living with this disease, lung cancer awareness is every day. Thank you for joining us, and a special hello to those who are viewing this program live. Please use the chat feature to ask questions or to post comments. Please know that this program is for informational purposes only and not intended to be medical advice. And this program will be recorded for playback on demand. My name is Katie Brown with LUNGevity Foundation. LUNGevity is the nation's leading lung cancer nonprofit, and we're changing outcomes for people with lung cancer through research, education, and support. LUNGevity initiatives position us as thought leaders in the lung cancer advocacy community, providing programs and driving change for those with lung cancer today and in the future. Our community partner for this program is the University of Chicago Medicine. With a history dating to 1927, it is a not-for-profit academic medical health system based on the campus of the University of Chicago in Hyde Park, and with hospitals, outpatient clinics, and physician practices throughout Chicago and its suburbs. UChicago Medicine unites 5 organizations to fulfill its tripartite mission of medical education, research, and patient care. Excellent. Our first speaker today is Dr. Marina Garasino. Dr. Garasino is an internationally recognized expert in the treatment of thoracic malignancies and specializes in thoracic tumors, including lung cancer, non-small cell lung cancer, and small cell lung cancer, as well as thymic malignancies. Dr. Garasino understands that thoracic cancers can grow quickly, so she works with her patients to accurately diagnose their condition and find the right treatment for each person. Full bios of our speakers today can be found on the agenda, and I will also drop a link to their bio page in the chat box. Welcome, Dr. Garasino. Please feel free to share your screen and begin whenever you're ready.
So thank you so much for giving me the opportunity to stay with you today. I believe that is so important to work with the patient advocacies in 2021, because I think that all together we can truly make the difference. And I am Italian, and as you can understand from my accent, I just came 8 months ago in the United States. And so I worked in a very big cancer center in Italy, and it was the National Cancer Institute, and it was the Cancer Institute where I think that the chemotherapy was invented. For the people that maybe they don't know, Bonadonna invented the anthracyclines, they invented the quadrantectomy, so it was a very huge cancer center, I think one of the most important in Europe. And it's funny because I came in the United States, and we have exactly the same problems in Europe and in the United States, because the story of lung cancer was totally different when I started to be a doctor 25 years ago, and it's totally different now. And you must be you must know everything very, very well, and also very quickly, because the advances are very quick and very important. So just to give you an update, so I think that this is a division that is not about the stigma of smoking, but is about how we approach the patients for the diagnosis of non-small cell lung cancer. So basically, we know that there are a group of patients who never smoked in the past, and they are characterized to have spatial alterations that we are going to see in the next slides. And I think that the target therapies in this population totally change the prognosis of these patients. On the other side, in 2018, the patients who smoked in the past, they had a lot of advantages from the immunotherapy. The immunotherapy radically changed the treatment of this population. And I believe that, so basically, when we see a patient, we divide and we ask the smoking history just to understand what is the most frequent treatment in this population. And in particular, what we know is that the people who never smoked are not so sensitive to the immunotherapy, while the people who smoked in the past, sorry, here I left never, but it's who smoked, they are more sensitive to the immunotherapy and the chemotherapy. So, starting from the target therapies, which is the topic of my presentation, is to make you aware how much it is important to make a correct diagnosis in 2021, because in 2021, we have so many treatments for patients where we find a target alteration, and we have incredible prognosis for these patients. Here you can see just, this is a slide of 2020, but you can see how many advances we had in the last 20 years for the treatment of advanced non-small cell lung cancer. And I think that, and now I tell you all the story, in 2004, we found the EGFR alterations, and since then, more or less every year, we found a new target and potentially a new tyrosine kinase inhibitors or inhibitors directed to the target. So the study was very nice because as you can see now in 2021, we have many drugs for all the alterations. Some of them, like EGFR, are in 10% of the overall population. ALK is less frequent, is just for 6%. ROS1 is 1-2%. BRAF is again 1%, 1%, 1%, 1%. But for all of them, we have a drug which targets exactly the target. And if we target the alteration, we can achieve a very long survival with a very good quality of life. However, after a while, we can have some mechanism of resistance, more or less like the antibiotics. And so the research now is moving to find new drugs against the mechanism of resistance. Among all the classical targets, there is one very new, which is the G12C in the KRAS. KRAS is the most frequent mutation in lung cancer, is about 20% of all the lung cancer alterations. And for the G12C is the most frequent alteration in KRAS. There are many variants, for which in 2021 we have 2 drugs. And now we are working on the combination with immunotherapy because differently from all the other, the G12C is very frequent in patients who smoked in the past. So then if you want, we can discuss one by one all these alterations, but this is just to give you an overview of what we can do in 2021. And I want just to tell you some part of the story, because I was a very young doctor in 2004. And when I told the people that I was treating lung cancer, all the people were very scared because they told me that I was treating the worst cancer maybe in 2004. But 2 groups in the United States made the study for target therapies because they identified that at the time there was gefitinib, that was an EGFR tyrosine kinase inhibitor. And 2 groups at the same time identified that there were a category of patients who responded a lot to the target therapies. And I can tell you that I think that we have all anecdotal cases of patients who received the gefitinib in very terrible condition and they have what we call Lazarus phenomenon. They're truly resuscitated after the target therapies. So we saw that there was a category of patients that they had a specific alteration in EGFR, and then they started the precision medicine in lung cancer. After EGFR mutation, 2 years after, we found the ALK translocations. 2 years after, we found ROS1, and then all the alterations that I told you. But what was very important in 2004 is that we were able to understand that when an alteration, a mutation, a translocations was present, there was an incredible activity of the drugs directed against the target. And you can see that this was the study. The study identified some alterations that were more frequent in 2 exons that were the exon 19 and the exon 21. Now we know other part of the study. There is in 2021, we were able to understand that there are different mutations in the exon 20 that in general, they are resistant to the first EGFR tyrosine kinase inhibitors, but now we have also drugs directed to the exon 20. And so we have this incredible long list. I received everyday phone calls from my friends around the world saying, hello, I have a patient with a RET translocation. What do I have to do? Because it's so complicated to treat patients in 2021 that sometimes really you need a specialized team and a good group to make the diagnosis. What I want to tell you that I believe is very important, this is a presentation that was done in ASCO 2021. And as you can see here, this was a retrospective analysis in many centers in the United States. And they collected really thousands of charts. And what was interesting is that the correct diagnosis with all the targets was done in less than 50% of cases. And so if you don't find the target, you don't give the opportunity to the patients to receive the correct drug and to have a very long prognosis. And in general, I think that we can discuss the target therapies. For the majority of cases, they are oral drugs and they have few toxicities or particular toxicity. Not all of them are without toxic side effects, but the majority of them allow the patients to live a normal life and to live the life that potentially they had also before the diagnosis of cancer. So I think that here, this is not in the United States, and as I said in the beginning, this is also in Europe. I think that we have to have more awareness about the fact that we need to test all the targets that we have in 2021, and not just 3 of them. And because if you make the correct diagnosis, you can really change the life of the patients. And I just want to give you an idea. This is the last target that we found. This is a very rare target. It is called NTRK. There are 3 isoforms and can be present not just in lung cancer, but also in other tumors and also in some pediatric cancer. But what I want to show you is how long is the prognosis of these patients. So it is now, and you can see that it can be also more. There are at least 40 months, which means a prognosis of years. And so this is why also, if this target is just maybe 1% of all non-small cell lung cancer, is important to test for all the targets, because you can move the prognosis of patients from months to years. And again, it is important to remember that in general, the patients harboring this type of alterations, in general, they are not responsive to the immunotherapy. So also to make the correct diagnosis in the beginning and making the diagnosis of the target alteration is important, not just to give the correct target therapy, but is important also because maybe these patients are not so sensitive to the immunotherapy and also to some combination with immunotherapy. I think that maybe Jessica will go through again. This is what we do at University of Chicago for the diagnosis. I avoided to put the radiation oncologist in this picture because they don't do the diagnosis. We do much more the diagnosis with the surgeons and with the interventional pneumologist and also with the interventional radiologist. But just to give you the idea that if you want to do a correct diagnosis, you need a team. You need a team and you have to discuss case by case, which is the best method to make the correct diagnosis for the patients. Because as I told you many times, if we miss the correct diagnosis, we can have trouble in the treatment of the patients, and in particular, the patients can have troubles. So my message is that we need a multidisciplinary team. I think that is important to work with the patient advocacies because we have to increase the awareness of the diagnosis in 2021. And one part that maybe can be part of the discussion is that something which is very new, but it can be only complementary and not an alternative to the tissue diagnosis, can be also the diagnosis on the liquid biopsy. But in any case, for each decision that we want to do, we need a team, and it's important that we discuss everything together because we can truly change the prognosis of our patient, and I would say also the quality of life. And so this is just a very quick introduction. I'm sure that this is just a prompt for the discussion. But I want to give you all my enthusiasm for the story that I saw in my career, because I started to see the people in the beginning of my career dying, and now I can see the patients. And I tell you that last year I published also a case report on JTO of a patient who was pregnant and he had a baby on target therapies. So I think that I can just share you all my enthusiasm for this incredible story that we had to see in lung cancer.
I love that. And I love your enthusiasm. That's what we need. We need that in the lung cancer space. I'm going to roll into our next speaker, and then we're going to do some discussion and some Q&A after we hear from Ivy. But our next expert is Dr. Jessica Donington. She is an expert thoracic surgeon who treats the full spectrum of lung, esophageal, and mediastinal conditions. Her focus is on the comprehensive and multidisciplinary care of benign and malignant chest diseases. Dr. Donington specializes in lung cancer and treats people at all stages, providing a personalized approach to diagnosis and treatment using the latest technology and innovations, including minimally invasive and robotic surgery. Welcome, Dr. Donington. Please feel free to share your screen and begin whenever you're ready.
Thanks, Katie. Much appreciated. Can you guys see my screen?
Yes.
Okay, kind of moved around, but okay. All right. So, let's go to a different mode. Better?
No, we don't see the PowerPoint.
We don't see the PowerPoint.
Maybe you have just to click on the presentation.
Let's start again. Oh my gosh, how you would think at this point we would have it all down.
See it now.
You see it now. I just have to leave it over here. Sorry. It's the whole screen to screen thing. How's that?
Yes.
Oh, you would think.
You have to click maybe the full screen
Still don't have a full screen?
in the PowerPoint. Yes, go down. Yes, here.
Is it full screen now?
No, you try again. It seems just.
All right, one more try, and then we're just going to talk.
After 1.5 years of pandemic.
I know. You would think. It just doesn't like me today. I don't know why. What do I have now? Nothing.
So yeah, we are seeing your entire presentation, like a presenter's view, not a full screen view. If you're, oh, some people
That
are
may
saying,
just be us. Yeah, some other people are saying they can see the full screen. So that might just be the panelists.
Okay, I have to say, I admit I don't know what's going on. When I hit share screen, it shows me twice my PowerPoint, so I don't know what that means. So I'm going with this. How's that? It's okay if you guys see this one that's not. I'm moving on. They're not that good at slides, believe me. So it's super excited to talk to you guys. Always excited to talk about early stage lung cancer. You know, it is such an incredibly exciting time in lung cancer. And I don't know if I feel bad or good that the advancements we've made in stage 4 disease are so incredible that I think people are forgetting a little bit that we actually are making advancements in early stage also. And I think it really has come a long way. And it's also important to recognize that a fair number of our lung cancer patients are diagnosed in the earlier stages of disease. Granted, stage 1 and 2 is only about 20%, but when you add stage 3, you now start to represent almost 50% of patients where surgeons could and should have some impact. And the reality is, one of the most exciting things that's happened at the same time that we've seen all these new targets and all these new drugs is we've also introduced lung cancer screening. And we are just starting to get data together about what that really does mean in the United States. And we're starting to see, if you look at SEER databases, that within screening age patients, we're starting to see an uptick in the incidence of early stage lung cancer, with a pretty steady decline in the number of people diagnosed with late stage disease. So even with bad uptake, we are starting to see the impact of screening, which will make the treatment of early stage disease even more important. And when we look at early stage disease, it always, for many years, was all about local therapy, all about controlling the tumor locally. But the reality is, when we did that, we expected still somewhere between maybe 20 and 60% of our patients to recur. And that's a terrible number. And so more and more we've come to realize that local control, even for the smallest tumors, is only part of the answer. And the reality is that a lot of our early stage patients require systemic therapy. And like we just learned from Marina in 2021, that can be chemotherapy, that can be targeted therapy, that can be immunotherapy. And the science of that is super hard. And that kind of brings up that concept of why a tumor board is so incredibly important. Because this is getting complicated and this is getting personalized, and it's not as straightforward as it was 15 or 20 years ago when we had just 1 or 2 options for our patients. And that's why tumor boards have really become where lung cancer patients have to go before they're treated, because what used to be totally straightforward now has a lot of options. And if you don't sit and discuss that with people of different specialties, you get kind of very zoned in to, this is what I do, and this is how I treat it, and this is maybe how I learned to do it 5, 10, 15, 20 years ago, without the insights from your colleagues in other specialties. So there is really good evidence of the impact of tumor boards improving survival for lung cancer patients. But with the introduction of additional therapies for stage 1 and 2 patients, it really does put a significant onus upon surgeons to make surgery better tolerated. I think when I trained, 20 years ago, we just wanted our patients to kind of survive. It sounds terrible to say, but we did. We wanted them to live through our operations. We wanted them to eventually get back to their good health. And that was kind of all we asked. But in 2021, that's not enough. It's not enough for my patient to live. They need to thrive, and they need to be ready as fast as possible to go on to additional therapies. And so therefore, everything we've really been doing kind of in the last 10 years in thoracic surgery is all about making procedures more tolerable. How do I make it easier for my patients to get through the procedure, get out of the hospital, and get ready for more treatment? And the three main advancements have been made in the last 10 years are smaller operations through smaller incisions, and then a more organized plan to get people through a hospitalization. Because we do recognize that having to come into the hospital is a big deal for any patient. I'll talk first about sublobar resections, and that starts with a little bit of discussion about what does an operation for lung cancer entail. So first we have to talk about the approach, which means how I get from outside to inside. Basically, how do I get through a patient's rib cage? And that's always a big hurdle in lung surgery because I have to go through the muscles that everyone uses to breathe. And that can make this a really challenging operation. And moving from thoracotomies, big incisions that divide all of the muscles on the chest wall, to a minimally invasive approach, be that with a VATS or a robot, has been a huge step forward in our patients because of decreased complications and faster recovery. But the next thing we talk about is extent of resection, and that's like a whole different kind of conversation. And that means, do I take the whole lung if someone has a cancer, or do I just take the lobe that the tumor is in, or are there patients where I can do less? The part of the conversation that doesn't have a lot of decisions, because we all know what the right answer is, it's just not always done, is whether we have to take lymph nodes at the time of the surgery, and that is always yes. Unlike breast surgery, there is almost no downside to taking as many lymph nodes as you can find at the time of a chest surgery. And as I describe it to my patients, you have hundreds and hundreds, and I need 10 to 20. And they're really, again, almost no complications, no long-term effects to taking those lymph nodes at the time of a lung cancer operation. So we're going to talk about extent of resection first. And this has been something which has been getting smaller over time. So the first resections for lung cancer weren't actually not done until the 1930s and 40s. Before that, if you had a lung cancer, there was no surgery for you. Unfortunately, operating in the chest is more complicated than amputating a leg or operating in the belly, and that was a huge hurdle to get over. And then they only took out the whole lung. And it wasn't until the 1960s that actually taking less than a lung came into vogue. And then there was a push in the 90s to maybe take smaller pieces. And they did this wonderful trial, where they randomized patients and some got a lobectomy and some got less. And the trial did show that if you did less, you had more risk of recurrence and maybe even a slightly higher risk of death. And so since the 1990s, no one has touched that. There's only one problem with that, is that this trial was done in the 1980s and 90s. And while that feels like yesterday, I was in high school. It's not yesterday anymore. And the reality is, in medicine, I feel like the 1980s may as well be the 1880s. We barely did CAT scans. We had no PET scans. We had none of these wonderful agents. We barely, everything was so different. And so this trial became super old, but as surgeons, we lived by this dogma for a really long time, despite the fact that CT scanners got so much better and so much less expensive, and everybody got one. Despite the fact that our pathologists got so much smarter and learned so much more about the tumors we were resecting, despite the fact that we started having screening and we were detecting itty bitty little nodules, we all lived by the dogma forever. And I think the dogma is changing. This was a trial that was done in Japan and reported this year, which compared doing a lobectomy versus kind of half of a taking just half of a lobe out for small tumors less than 2 centimeters. And what they found was if you took less than a lobe, people actually lived longer. So again, not for every tumor, not for people who come with big masses or tumors over 2 centimeters, but when we find those itty bitty little tumors in screening, maybe it makes more sense to leave a little bit more lung in there, because we want these patients to, again, not just live through our operations and not just live for 5 years, but we want these patients to live for 20 and 30 years. And that's where they kind of started to really find differences. It wasn't really just at 5 years, but what happens 10 years after an operation? And how beautiful is it that we can have survival curves 10 years out in lung cancer and really talk optimistically about what that should be. This trial actually brought up that concept in the surgical field. Is 5 years enough? Should we be looking at 10? Because 5's not enough anymore. We want our patients to live a lot longer than that. And that is super exciting. Next, minimally invasive resections. I think we have gotten to the point in the United States that that big incision on the left is no longer acceptable for patients with stage 1 disease. It's just not. We have had VATS techniques available since the 1990s. Once we learned how to do what we call the special one lung anesthesia, where someone breathes on one lung and we operate on the other. And since we had the good video equipment, and now like no one in the United States is gonna get like, I don't know, like their gallbladder out with a big incision unless they're super sick. No one's gonna get bariatric surgery with open procedures unless something's up. And the same has to be true for lung cancer. You just cannot, we cannot accept people getting a big incision for a straightforward small tumor. And the reason for that is that we know the outcomes are better. And again, we've had lots of, looking at my studies and this and that, but we really got a great trial a couple years ago that kind of took 500 patients and said, okay, half of you are getting open and half of you are getting a closed operation, and we're going to look. And it was hysterical. Not only did they blind, the only people who weren't blinded to what was going on were the surgeons. They actually put all the patients in a big binder after surgery, and neither the nurses or the patient knew what they had until the patient left the hospital. And what they found was less pain starting right away. Decrease opioids. How important is that? That we're not sending our patients home with hundreds of pills for opioids. Fewer complications, the same operation from an oncologic standpoint, and dramatically less cost. Because again, if people aren't sick, don't need to go to the ICU, they do a lot better. The surgical robot has really changed the face of minimally invasive surgery. I know it'd be great if the robot was super sexy and cute, but this is what the surgical robot actually looks like. It's not sexy at all. But it's an amazing tool that has really made it so much easier for surgeons to move to minimally invasive procedures. And that's because it has wristed instruments that move a lot more like your normal hand than the instruments which I use for VATS, which are a little bit more like chopsticks. And I think that has really helped it. I always say it really helps women too, because you get to be four-handed all of a sudden. It's so awesome to multitask with 4 hands. My house would be immaculate if I had 4 hands, but it really is fun in surgery to be four-handed. One of the things that's challenging about the robot is a totally different system, but also the fact that you have to scrub out and sit in the room, not at the bedside. But again, we're at a point now when most hospitals have this, even though it is a large capital expense. And most of us have really well-trained assistants who know what to do and how to work at the bedside. But again, this has been huge in helping thoracic surgeons transition from open procedures to minimally invasive. So a huge advancement for our patients. And the last thing is something that sounds so simple, but it's called an enhanced recovery pathway. These pathways were put together first in colorectal surgery, which is also going through a change similar to what we are in lung surgery. And then thoracic has been the next field, which has really jumped on this. And the concept is just how do we put together a set of rules and a workflow that is always trying to decrease the impact of surgery. We're trying to make it less painful, less time consuming, less everything. And a lot of it is completely intuitive. It feels like, but until you write down, you know, all 45 or 50 steps and say, we're going to do every one of these in every patient, things get dropped. And that's the advantage of having a program. So it's lots of non-opioid pain medicine. How smart is that? That Tylenol treats pain. Didn't we learn that like in second grade? But I think in medicine, we somehow forgot about that. But it works. Tylenol treats pain. If you use it all the time, guess what? You don't have to use opioids as much. Educating your patients, giving them educational materials that they can take home and learn about. And then engaging your anesthesia teams to use certain anesthetics that don't stick around as long. Not having to starve your patients before surgery, letting them drink up to the time of surgery. All these things help. Getting people up and out and realizing that most people recover better at home than in the hospital. And when these plans have gone into place, not only do we see decreases in costs and complications, but the one I find most exciting is we find, I know it's not the best graphic, but we find that patients are able to move on to adjuvant chemotherapy faster and more at a greater number. So again, not enough to survive. You need to thrive and be ready for that next step of treatment. And by putting people on an organized plan like that, we are more likely to allow them to return to the rest of their cancer treatment in time. So it is an exciting time in early stage lung cancer. We have made tons of advancements, and luckily those have gone hand in hand with what's going on in advanced stage disease. And I think we are well on our way to really making a difference in terms of survival in this disease. So thank you for your attention. I hope I didn't lose everybody with my bad AV in the beginning. Forgive me.
It's fascinating, and I learn something every time I hear you speak. Do you mind, since we have just a little bit of time before introducing Ivy, if I ask a couple of questions that were pre-submitted to us?
No, please.
So the one question that we get often from folks who are not early stage lung cancer is surgery ever recommended for later stage lung cancers?
So it is. So again, this is where the tumor boards are so important. So for patients with stage 4 disease, and especially those who present with very limited stage 4 disease, or what we might call oligometastatic, meaning maybe less than 5 sites, actually performing either surgery or radiation to the primary tumor, if someone has done well with their initial chemotherapy or targeted therapy or immunotherapy, is actually becoming standard of care. And that's sometimes called local consolidative therapy. And whether it could be surgery or radiation right now, we don't know if one is better than the other. Even for patients who have non-oligometastatic disease and have had a really dramatic response, and we see this most typically so far with the targeted agents, you can do what my tumor board calls an IV approach. Based upon our really satisfying and really great approach when we treated Ivy at our institution. And she will tell her own story. But yeah, in patients who have a really good response to their targeted agent, we are more and more discussing, is there a role for removing any residual disease, because we know resistance develops. So if we find one spot that's got all those tumor cells and we don't want them to have a chance to become resistant, my understanding is that when they're in the pathology suite, they have a lot less chance of becoming resistant over time. So I think maybe Marina can comment too as to how I don't think we're out of bounds in saying that this is becoming an accepted approach in stage 4.
Yeah, I fully agree with you. And again, it's key, the multidisciplinary tumor board, because it's a common question of these patients with stage 4. Why do not I receive the surgery? And so this is, I think that all the patients ask when they come if they have metastasis somewhere. So And I think that if there is a good multidisciplinary tumor board in the oligometastatic patients, or when we have exceptional response with target therapies and there is only one lesion left, 2 lesions left, I think that this can be an opportunity for surgery or for radiation therapy, so for local approaches. But again, I think that this is a common discussion that we have all together to find and clearly there are very few randomized clinical trials in this space. So it's very difficult to find evidence. So I think that the personalization of the treatment for patients is really crucial.
That's so hopeful. That's just, just gives me chills. As someone who lost her father to lung cancer in 2002, I've been able to see a lot of the progress, and what you guys are doing is absolutely amazing. I do have more questions, which I'm going to save for the Q&A, but right now I would love to introduce our next speaker. Ivy Elkins is a lung cancer survivor advocate and one of the co-founders of the EGFR Resistors, a patient-driven initiative to understand and improve treatments for EGFR positive lung cancer through collaborations with researchers and advocacy groups. She is a dedicated advocate for lung cancer research, having served 6 times as a consumer reviewer for the Department of Defense Lung Cancer Research Program, reviewed grant proposals for ASCO's Conquer Cancer, twice completed the AACR Scientist Survivor Program, mentored other research advocates through the IASLC STARS program, and acted as advocate faculty for 3 years for the ASCO AACR Methods in Clinical Cancer Research Workshop. Welcome, Ivy, and please feel free to share your screen and begin whenever you're ready. You're muted.
Hi there. Sorry about that. I didn't realize I was muted. I seem to now be having, can you see my screen now? Let's see. Now let me see if I can get it on full. Bear with me 1 second. Slideshow. Okay, there we go. Can everyone see now? Okay, I hope so. Okay, hi everyone. Thanks for the introduction, Katie. As Katie said, I'm Ivy Elkins, and I'm a patient advocate who has been living with stage 4 lung cancer for almost 8 years. I'm going to share my story with all of you today about both my personal and advocacy journeys, and also talk to you about the importance of lung cancer advocacy. I live in Evanston, Illinois, just north of downtown Chicago. I've been married for 25 years, and I have 2 sons, currently 18 and 21 years old. When I was diagnosed with stage 4 EGFR positive non-small cell lung cancer in December 2013, my boys were 10 and 13 years old. The first picture up on the screen was taken just about 1 month prior to my diagnosis. In the middle of 2013, this is when my story started, I began having some pain on the left side of my neck and difficulty straightening my elbow. And initially I didn't think much of it, but as it didn't get better, I went to my primary care physician, and he diagnosed me as having an overuse injury, probably due to just using my computer too much, maybe not having a good posture, that type of thing. I had an x-ray of my elbow at that point, which was clear, and an MRI of my neck, which showed just mildly degenerating discs consistent with my age of 47 at the time. my doctor then recommended that I go to physical therapy, and that seemed to make sense to me. So over the next 6 months, I went to 2 different physical therapists, 2 different orthopedists, a rheumatologist, and tried numerous exercises and cortisone shots for my elbow, which just wasn't responding to normal treatment and kept getting worse. So people kept sending me from one doctor to another. Finally, I had an MRI of my elbow, and the MRI showed, remember, nothing showed up on an X-ray, but the MRI showed that there was a mass on the bone, which had partially eaten away at the joint. I then visited an orthopedic oncologist who said that he was pretty sure it was benign, but scheduled a biopsy to double check. Now, unfortunately, when the biopsy results came back, it wasn't benign. It was a type of cancer called adenocarcinoma that doesn't originate in the bone. So then the doctors needed to find out where my cancer originated. So I had a PET scan. And it turned out that the origin of the cancer was a tumor in my right lung that had already spread. That's why I was considered stage 4. It had spread to my bones. So my elbow, my neck, even though it didn't show up on the initial MRI, it was very high up in my cervical spine. I had small lesions also in my ribs and my pelvis. And then because lung cancer often travels to the brain, I had a brain MRI, and that showed that I had 8 small lesions in my brain also. So I was just, shocked and devastated, without words. I had no idea that I could even get lung cancer. It wasn't on my radar screen. And I didn't have any of the traditional side effects that I associated with lung cancer, like coughing or wheezing or shortness of breath, nothing. So what I didn't know then, what I know now, which is really that anyone with lungs can get lung cancer. And I also didn't know that not all lung cancer is the same and is not treated the same. So there was a lot I didn't know when I was first diagnosed. Fortunately, I found a fantastic thoracic oncologist. I'm pictured up there with her, Dr. Josie Patel, and I had biomarker testing. And here is where the importance of biomarker testing really shows. This was in 2013, so there wasn't as much testing for different mutations as there is now. So I was just tested for EGFR, ALK, and KRAS. But fortunately, we found out that my lung cancer was driven by a mutation in EGFR. As a result, I have been treated successfully, very successfully, with oral targeted therapy, a daily pill, these past almost 8 years. My first targeted therapy worked for almost 3 years, and very soon after I started treatment, my brain lesions completely disappeared. Bone healed over and grew back in my neck, elbow, and other areas. And the main mass that I had in my lungs, which was, I think almost 3 centimeters when I was first diagnosed, shrank significantly. In 2016, so 3 years after I was diagnosed approximately, I had some progression in my original lung tumor. I had repeat biomarker testing and began a new targeted therapy for a mutation called T790M that I had developed. I was fortunate to have further shrinkage in my original tumor in my lungs, and none of my other areas, brain, bones, showed any more activity. So just about 2 years ago, I had a PET scan that showed that the only area of identifiable cancer I still had left in my body was the original primary tumor in my right lobe. So this is where Dr. Jessica Donnington came in, because I had a lobectomy to remove my upper right lobe that she performed. And, so I'm living proof that yes, there can be surgery done for stage 4 patients. I've been considered NED, which means having no evidence of disease, for almost 2 years. And I continue to take my targeted therapy medication daily, because I know there's always a chance of recurrence, but I am doing great. So I'm really telling you my story to show how critically important molecular testing and new treatments like targeted therapies are. I'm only here today because of research in these areas. I mean, when I was first diagnosed, the medication I take today daily didn't exist. And I never thought I would become eligible for surgery as a stage 4 patient, let alone become NED. Those two little boys in the first picture up on your screen are now both big college students, and I've been able to live well with lung cancer while raising them with my husband. I was introduced to LUNGevity by a friend whom I met soon after my diagnosis. Some of you may know her, super advocate and patient Jill Feldman. It took me a little while to feel ready, but I soon met others in the lung cancer community through attending a LUNGevity event here in the Northwest suburbs called Breathe Deep North Shore, and traveling to the annual LUNGevity Hope Summit for patients and caregivers in Washington, D.C. I started telling my story, fundraising, and supporting other patients. I found that I really wanted to learn more about the science of lung cancer and keep informed about research and development efforts. So I started reading journal articles and attending conferences like ASCO, the American Society of Clinical Oncology, which is held right here in Chicago. Now, my background is definitely not in science. I have an undergrad degree in English and an MBA in finance. However, as I started to learn more about research, I found that this was the area where I wanted to focus my advocacy efforts. I know that I'm alive because of research, and I wanted to find a way to share my perspective in order to help scientists better meet the needs of patients like myself. Now, let me back up just a little and talk about what it means to be an advocate. As I mentioned before, it took me a little while to feel ready to go out, meet others living with lung cancer, and share my story and perspectives publicly. I had to get used to being a patient before I could become an advocate. As a patient, I started to learn about my disease, but focused mainly on myself and my treatment options. I felt very emotional about my diagnosis, which of course is completely normal, but I couldn't really separate these emotions from the decisions I made. I couldn't even talk about my diagnosis without crying. I was still grieving the difference between what I had expected to be my life and my sudden diagnosis with stage 4 lung cancer. However, once I started getting more involved in LUNGevity, I realized how much hope there is today for those of us living with lung cancer. There has been an explosion of new treatments for all stages of diagnosis. And there's so much exciting research and development on the horizon, and I wanted to be part of this. I gradually moved into advocacy for lung cancer as I developed more in-depth knowledge about the disease. I began applying for advocacy programs. I'll talk about a few of those in a minute that could get me started in focusing on influencing research and representing the greater lung cancer community. Each one of my advocacy activities has really built on the others and given me increasing amounts of visibility and credibility. I didn't become an advocate overnight, and I still have a lot of learning that I do along the way. I'd like to make sure everyone knows that there are many different ways to be a lung cancer advocate. If this is something that interests you, it's important to find the way that gives you energy rather than drains you. You should advocate in a way that you enjoy, that uses your strengths, and that fulfills you. There are no requirements in advocacy. You can do as much or as little as is possible for you, given all your other priorities in life. Many people advocate for overall lung cancer awareness. Like I mentioned earlier, I, like many others, didn't even have lung cancer on my radar screen. So there is a huge need to educate the public that anyone with lungs can get lung cancer. You'll see a picture of a group of us on this slide holding these large white ribbons. And this is important. These ribbons come from a grassroots advocacy movement called the White Ribbon Project. And I just recently participated in a University of Chicago webinar about this White Ribbon Project with the founders of the project, Heidi and Pierre Anda. Basically, through this project, anyone can be an advocate by ordering a white ribbon, they're free, and displaying or sharing it. So if you want to learn more about this project, check out www.thewhiteribonproject.org online. Others like to support fellow patients and caregivers, and this is very important too, because no one should feel alone with a diagnosis of lung cancer. LUNGevity has a fantastic program called Lifeline Support, which I'm sure Katie will talk about a little later. But through this program, a patient or caregiver can be matched with someone similar to them for direct one-on-one support and assistance. Still others participate in political advocacy, where they work to increase the funds that the federal government, say, allocates to lung cancer research. Lung cancer research is definitely underfunded compared to other cancer types. Political advocates may visit DC, storm the Hill, and participate in other lobbying efforts. There are also local opportunities to participate in local government efforts to improve laws for various different topics, such as biomarker testing in many states. Last but not least is research advocacy, which is my true focus area, as I mentioned before, where advocates work with scientists, researchers, oncologists, pharmaceutical companies, and other industry members in order to share the patient perspective and make sure research meets patient needs. I'm just going to quickly highlight a few research advocacy opportunities that I've participated in. The DoD, the Department of Defense, funds medical research on a variety of disease states, including lung cancer, and puts together panels of scientists and patient advocates to review the proposals that are submitted for funding. Patient advocates who participate on these panels are called consumer reviewers. Consumer reviewers need to be recommended by advocacy organizations. I was actually recommended by LUNGevity, complete an application, and interview with someone from the program. I was placed on my first panel as a consumer reviewer in 2016, and I've participated in 8 panels total now. The last few have been virtual. It's a really exciting program because as a patient advocate, you get to work directly with scientists to discuss the pros and cons of various proposals that are up for potential funding. Often there are things that we as patient advocates living with a disease bring up that scientists haven't really thought of because they're so deeply entrenched in the science and don't always get to talk to patients. Everyone gets an equal vote on each proposal. So consumer reviewers' opinions are as important as those of the scientists on the panel. Another program is AACR's Scientist Survivor Program, which I learned about at lunch with some researchers during my first DoD panel. Again, I completed an application and got recommendations in order to apply for participation. AACR focuses on scientific cancer research and has a number of conferences throughout the year, including an annual meeting. The Scientist Survivor Program provides a special additional track at AACR for patient advocates with separate lectures, small group workshops, and tons of opportunities to connect and ask questions of researchers. It was a great experience because I got to meet and work with advocates from all different cancer types, which was a fantastic way to make new connections. I also learned how to create and present a scientific poster, got to attend special focused receptions for advocates, such as a reception with the FDA and many other things, all in addition to actually being there to attend the AACR annual meeting. Other conferences, in addition to AACR, have programs like this as well to encourage and support research advocacy. A really excellent program that's relatively new is the IASLC's STARS program. This program focuses specifically on developing research advocates for lung cancer and teaches participants both the science they need to understand in order to be an effective advocate and ways to improve their communication skills. Those who participate in STARS learn from each other, from subject matter experts, and from mentors who are more established research advocates in the lung cancer community. The program culminates in a trip to the World Conference on Lung Cancer, where participants can put their new skills into action. Then they take these skills back to their communities with plans for future advocacy work. There are also opportunities to advocate for the specific type of lung cancer that you might have. As I mentioned earlier, I learned that not all lung cancer is the same and is not treated the same when I was first diagnosed. As a matter of fact, and Dr. Garasino talked about this earlier, there are many different types of lung cancer. The pie chart on the left shows that first, lung cancer can be broken down into two main types, non-small cell and small cell. Adenocarcinoma is the most prevalent type of non-small cell lung cancer, and recent research has shown that there are a large number of biomarkers that can drive adenocarcinoma. You could see all of these in the pie chart on the right. Different biomarkers can mean different treatments, precision medicine treatments that are directly targeted to the genomic changes that cause cancer, like my EGFR mutation. Biomarker testing and therapies targeted to these biomarkers have allowed people with lung cancer to live longer and better lives in the past 5 to 10 years. As a result, they've been able to take a larger role in advocating for themselves and others, because when you feel well and you're doing well, you can look outside yourself and, figure out how to help groups of people. This slide shows the patient groups that advocates have formed for many of the biomarker-driven cancers on the pie chart you saw on the previous slide. These groups are often patient-run and determine their own agendas, focusing on what they feel are unmet needs in their subset of lung cancer. However, they all have in common what they offer patients, and this is hope, support, education, empowerment, and connections. Many people who join these groups have never met other people living with lung cancer, let alone a tribe who shares their specific type of lung cancer. Many of the groups also participate in patient-driven research. This is very important because as patients, we have critical information to share and a unique perspective. Patient-driven research can help scientists learn about disease biology, develop and test new treatments, identify best practices, generate ideas for new studies, and support regulatory approvals. One of these groups is the EGFR resistors, which I co-founded with 6 other patients and 1 caregiver in the middle of 2017. We decided that we wanted to build a community of patients and caregivers to share knowledge, provide support, and work to accelerate research with the goal of improving outcomes for EGFR positive lung cancer. We created a closed Facebook group for patients and caregivers only and communicate with the broader EGFR positive community through our website, Twitter, and Instagram. We have a monthly newsletter that anyone can sign up for on our website, so I encourage all of you to do so if you're interested in learning more about our work. Please also follow the EGFR resistors on social media. Our initial group of 7 founders has grown since we started to over 3,100 members from almost 90 different countries. We've created many collaborations in order to fund and accelerate research, but I'm just going to really quickly talk about a couple of them right now. One of them is a patient-driven partnership with LUNGevity called Project Priority to study the real-world experience of living with EGFR-positive lung cancer. We surveyed our members in order to learn more about their unmet needs, areas for improvement in diagnosis and treatment, and patient and caregiver concerns. Based on our findings from Project Priority, we created another collaboration with LUNGevity to select and fund 2 research projects to begin to address these unmet needs and concerns. And I'm not going to go into details about them right now, but I just put these up on the screen because I want you to see that a lot can be accomplished when patients work together and advocate for improvements in their own disease. In summary, I hope that I've shown today that there is a lot of hope for those of us living with lung cancer. There are more treatment options than ever before available to us, and lots of promise for additional ones in the future. There are ways for us to advocate for our needs in order to drive increased awareness and research for lung cancer. LUNGevity's vision is a world where no one dies of lung cancer. I share in that vision and hope to see more and more people with lung cancer be able to manage their cancer as a chronic disease in the not too far future. Thank you so much.
Thank you, Ivy. That's amazing. We have some time for some Q&A, but since you just finished your presentation, can I start with you?
With me? Sure, of course.
Yes. So what is your advice for someone new to advocacy?
I think if someone is new to advocacy, the first thing they should do is figure out, I kind of touched on this a little bit in my presentation, how they want to advocate. And sometimes you can't figure that out until you've tried different things. So, try things. It doesn't mean that you're locked into that, forever. Let, someone at LUNGevity know, like Katie, that you're interested in advocacy. You'll find opportunities through them to share your story. You can find your own opportunities to share your story. It doesn't even have to be that formal. It could be at a school your kids go to. It could be at your church or synagogue. Do some reading, see if you're interested in research. Look at information about political advocacy, and, just try to, sign up for some programs where you can learn more. There's a lot of them around, and figure out what you enjoy. And then if you enjoy it, keep doing it.
Katie, can I just take a minute to introduce Cammie to our audience?
Absolutely. I actually have been talking with Cammie in the chat.
Oh, okay, thank you.
I have a couple of questions for her as well, so I'm moving that way.
Okay.
And also, Ivy, what are some of the, I guess, fulfilling benefits of being an advocate, a patient advocate? Because patients, all of us, our hands are full with treatment and worrying about the next scan and this and that. What are some of the benefits, personal satisfaction of becoming an advocate?
In becoming a patient advocate, and I didn't mention when I talked about the Lifeline program, is that I've been a Lifeline mentor, a number of times, and I also frequently have, just through word of mouth, patients refer to me. I find it so personally satisfying to be able to help someone, with something I didn't know about when I was first diagnosed, but then I learned and I can pass it on. And sometimes, it's just listening and providing support that, anything's possible, and don't believe the statistics, and, there's new treatments. But sometimes it's even more specific when, I can tell someone, say in the EGFR resistors group, hey, you're progressing. You really need to get a new biopsy. Sometimes, it could be so, life-changing by just, passing along a little bit of information, that it's incredible that you can help someone in that way. And it's just, I wouldn't be here if I didn't have people who helped me at the beginning like that. So I just feel like it's important to pass on, that assistance and the ability to just, share advice and best practices, really.
Absolutely. Absolutely. Fantastic. And I just want to echo what Ivy says. You don't have to have a background in science. You don't have to have a medical background to, number one, advocate for your own self and your own care, and then also to become an advocate in the lung cancer community. Thank you.
And I don't think we can understate how much more powerful a survivor's voice is than that of a scientist. I think, we have our role and we have important things to say, but the reality is when Ivy says them, everybody listens, and most of us get chills. So
I agree.
Absolutely. Well, I do want to bring on Miss Cami. I don't know if she's able to turn on her video, but maybe she's able to unmute. So there we go. Oh, I just muted her.
Good afternoon. Can everybody hear me?
Yes.
Yeah, I apologize. My video isn't working on my computer. I tried everything, but Ivy, you are very impressive. I learned things from you that I didn't even know, and I've been a thoracic oncology nurse navigator for 4 years now.
Thank you so much. And
yeah,
thank you to everyone on this panel.
Yeah.
I really appreciate everyone's kind words.
Yeah, it's just you're an amazing individual, and I'm very happy for you. So thank you for inviting me to join the panel.
Absolutely. Cami, can you give us a little bit of background on you and what you do at the University of Chicago?
Yeah, so I am an oncology nurse navigator. What we basically do is remove barriers to patients' care. We provide psychosocial support. I also support Dr. Garasino in the medical oncology department. And I'm really into patient education and helping patients understand their disease and their lung cancer, and helping their families as well. I am certified as an advanced oncology clinical nurse specialist and an oncology nurse navigator, thoracic. So I have both of those certifications, and I'm very passionate about oncology, and especially lung cancer, because it's been a very exciting world the last 5 years for the lung cancer patients.
Absolutely. So I'm going to take you back, and these questions are for you, Cami. A patient is newly diagnosed, and Ivy may or may not be able to relate to this, but when I was diagnosed with my disease, I completely blanked out right after the doctor said, you have XYZ, right? And I wasn't listening to anything. And then somebody handed me a piece of paper, and that was supposed to be my treatment plan. A big disclaimer, not treated at University of Chicago. Okay, so Cami, when a patient is diagnosed at the University of Chicago, who helps them navigate the health system there? And what types of supportive resources do you guys have available for lung cancer patients?
So when a patient is first diagnosed at the University of Chicago, it is generally with our pulmonologist or our CT surgeons. And they both have marvelous groups of physician assistants and physicians. And at that point, then we discuss them usually in tumor board, and then they are sent to the medical oncologist and or the radiation oncologist. I work with Dr. Garasino, who's the medical oncologist, and I meet the patients with her when they first come in. I am their navigator, so I am the one that helps them navigate the system. I do their initial education. If we do the Guardant Health, which is a blood test that we do to find mutations, I'm the person that educates them on that. And I'm just like the first point of contact when they come to the medical oncologist. If they go on to chemotherapy, or if they go on an oral targeted agent, we have a big team as far as that goes as well. We have an excellent PharmD, and we have an excellent oncology specialty pharmacy that assists the patient if they are on a targeted agent to get the agent and to also help with financial assistance. We also have financial navigators. So if a patient expresses to me that they may have difficulties with finances, I refer to them and they contact the patient. We have an excellent dietitian, and often I ask our dietitian to see patients if they're in the chemotherapy suite. Our lung cancer patients often have problems with appetite or have already experienced weight loss. So she's a very important resource for our patients. We also have an excellent social worker. She gets involved as soon as, sometimes even before I meet them, especially if they need transportation. We have a palliative care team with 2 physicians and a nurse practitioner. And especially if a patient has an advanced stage lung cancer, I get them involved as soon as possible. They often help us with the symptom controls, especially pain. We also have pulmonary rehab for our patients and a very strong smoking cessation program. So if a patient is still a smoker, we can refer to that as well. And luckily with COVID, it has made the smoking cessation be a virtual platform, and a lot of patients are really loving that.
Yeah, and we discuss always about the multidisciplinary tumor board as a family of doctors, but I think that really we need a lot of people to work with the lung cancer patients that are not only doctors, but are nurses, PAs, social workers. So I think that we have to take care of the people and not of the cancers. And to do that, I think that we truly need a lot of people behind. So I think that this is very important, and also that all the people get along, that they are very well integrated. And yeah, we have to try to do our best like an orchestra, maybe.
That's a great example. So since
Can I add one more push for a new program we just had a meeting about this morning? So specifically to our lung cancer program, we are working to add acupuncture also, as we see that, you know, symptom control is a big issue for our patients. And we have a very holistic view to all of the symptoms associated with lung cancer. So we hope to have that in place within the next 6 months.
That's amazing. I love that. I love knowing that. So this question could be for both doctors Garasino or Donington, whoever wants to take it. I've just been diagnosed. I have no idea what a tumor board is. Can someone explain that to me?
I can start. So most common cancers or current cancer types within an academic medical center will have usually a once-a-week meeting where all of the specialists who treat that disease get together. So for the lung tumor board, that's medical oncologists, it's radiation oncologists, thoracic surgeons, along with pathologists, radiologists. Who am I missing? I'm sure I'm missing somebody. But the group within our hospital is like 25. It's a really large group of people. And so to the tumor board, some tumor boards will bring every patient they see with that disease. Some will just bring those that are complicated. But more and more, there's really good evidence that bringing every single patient you see to the tumor board and letting the group review them is really important. Patients don't come to the tumor board, so it's very rare to have a tumor board where patients participate. In general, your case is presented by one of the teams, and we all look at the films, and we all look at the pathology, and we have a discussion. And for some people, the discussion is pretty small. Wow, yeah, we think you should do that, and the patient kind of goes on their way. But even in straightforward cases, it's where we share ideas. Have you thought about this? Did you think about that? Just this morning, I read a paper that said this, and in the chat goes the paper, and everyone gets to read it. So it's where we discuss our most interesting patients, but also where we share our ideas. Did I miss anything? But as care gets more personalized and more complicated, it's ever more important than it was before. Like we said, 20 years ago, there were just 4 treatments. There was nothing to discuss. It was easy. You know, you could have gotten out of 8th grade and treated lung cancer. It's not like that anymore. It's complicated. It's personalized. And personalized is not only personalized to your tumor, it's personalized to the patient. What works for you, your age, your gender, your social set, all those things matter. And it really is important.
Absolutely.
And I did want to add, we have a very strong clinical trial program. I think that's something that we've left out in our conversation just now.
Oh my God, don't tell the head of our cancer center, they'll kill us.
To that effort, I was going to ask that next. So thank you, Cami. I would love to talk about clinical trials, because in the 20 years that I've been in the lung cancer space, clinical trials, there are lots of misconceptions about clinical trials. Lots of patients have said to us, oh, that's just a last ditch effort. But we all know that clinical trials can be viable treatment options and extend lives for patients. So can you guys talk a little bit about clinical trials? What are they, and why patients should be asking questions about them?
So maybe I can start, because I think that I have the majority of them. So I just want to tell you a story. So in 2012, immunotherapy was just a clinical trial in few centers in the world. One of them was just for chance University of Chicago. And at the time I was in my previous institution in Italy. And we had the randomized clinical trial called Checkmate 57 and 17. And I was trying to find something that could replace docetaxel as a second line for the treatment of non-small cell lung cancer. It was 2012, and still now I have the patients alive in the trial. This means that the story of the clinical trials was complicated in the last century, because there was also some part which was unethical in Europe and also in the United States. But now everything is approved by an ethical committee. There are very strong rules to guarantee to the patients that they have at least the standard treatment. So basically the patients with the clinical trial, they have a chance to have potentially something more than the standard treatment. And there is some old literature, it was about 7 or 8 years ago, suggesting that patients on the clinical trials, they have also better outcomes. And this is because sometimes it can be also the most frustrating part for the patients. We have to control the patients all the time during the clinical trial for the safety, for the efficacy, for the side effects, for the patient-reported outcomes. So at the end, these patients are much more in the hospital or in the video visit now, than other patients. And so we believe that the patients in the clinical trials, they have better outcomes, not just because they have the chance to receive a new drug, but because they are followed much more than the routine patients. So for the patients that are connected, I believe that is always a great opportunity. In my life, I had the great chance to see at least 3 times a revolution in lung cancer, and the patients who participated to the clinical trial, they had the chance to live more. And clearly, you must, the patients that wanted to participate to the clinical trials, they must be very motivated, because they have to come to the hospital maybe more times. They have to find the parking more times. You know that there is a funny paper that was what is your most important side effects for the oncological treatment? And there was also a funny answer that was find the parking, and it became the most relevant issue for the patients. So we are speaking about safety, but also the logistic is important. But so I believe that the patients must be very motivated, because we must be compliant with the rules of the clinical trials. And so sometimes can be hard for the patients and also for the family, but it's clear that in the majority of cases, the patients receive more, or at least the standard of care. There is always the question, why do we need the randomization? And so sometimes, and I want to hear also your voice, sometimes the patients are scared that a computer decides if they go in one arm or in the other arm. I think that this is a protection, because you know that the first clinical trial was done when, you know, when there was the discovery of the America, and there was the scorbutus, and it's correct to say scorbutus, the ASIC vitamin C absence.
Oh, ascorbic acid, yes, vitamin C.
Yes, and so the captain of the boats understood that the people who ate oranges were without the absence of vitamin C, and they didn't die at the end of the trip. And so the first randomized trial, the captain divided 2 groups in the same boat and gave the oranges only to one group and not to the other. And at the end, all the people who arrived in America or in Europe, I didn't remember the direction, he had the clear answer that the vitamin C was the possibility to avoid the disease. And so now the boats started to have a lot of oranges, lemons, to move from one country to the other. And this is why the randomization is the only way for which we have clear answer. And if we have the clear answer, if the standard of care is superior or not, or at least is the same to the experimental treatment. So I think that to preserve the integrity of the clinical trial is very important, and the patients must not to be scared, because they can receive something more and not something less. I don't know if you want to add something else. I think that the patient perspective for the clinical trial is so important.
Ivy, do you want to?
Yeah. Well, I'd just like to add that, I think it's important also for patients to know that there are 3 different phases of clinical trials. So, in early stage trials like phase 1 trials, you won't be randomized. Usually you are just getting this brand new experimental treatment, which may have been, tested in cell lines or in animals prior, but it's the first treatment that you have in humans. And while that could sound a little bit scary, sometimes that is the best possible treatment option. Also, it's a way to access these new treatments before, they're approved. If you think about it, like the treatments that, someone is on, like, for example, what I'm on now that's working for me, I'm only on because there were people who were able to access that in phase 1, phase 2, and phase 3 clinical trials. So, I mean, the important thing is for patients to not necessarily think about these as a last resort, but as an option to get a treatment, that is brand new, that might work great for them, or might not, because you never know, but might work great for them, way before it goes through, what can be sometimes a lengthy approval process. So it's just really important to ask your oncologist about clinical trials, and don't assume that, just because maybe you're just starting your journey, there isn't something available for you, because I know that there are a lot of clinical trials that are looking at upfront treatment options, taking the standard of care and adding something to that. So that's also important to consider, things that might prevent resistance from developing, that you can start with early on. So lots of things to look into.
Yeah, again, when I started to be a doctor, the phase 1 were just to find the right dose. And now also in lung cancer, you saw the results in ASCO 2021 for the treatment after maybe osimertinib in EGFR mutated. They were very active and they were phase 1 trials. So I agree that you have to discuss with the doctors what is the possibility to have experimental drugs again. So yeah, and if I may, I would add also one part, which is clearly when we are speaking about trials, we are speaking about experimental drugs, but there is also one part which is very important for us as researchers, which is the biobank. So to make progresses, we need the donation sometimes of blood, tissue, and feces. This is really a gift that you can do to the next generations, because we can find new targets, new molecules, new biomarkers, which means the possibility for us to personalize better your treatment if you donate the blood, the tissue, and with Jessica, we are working also on doing the organoids. The organoids are some new possibilities to test the pharmacological, to do a broad pharmacological screening without the mice, the animal experiments. So, and we can do this because the patients donated the tissue, and we can create this kind of structures that are able to recapitulate the human, and we can test maybe to simultaneously 1,000 drugs at the same time, and we can find, we can really foster the research. So if you are asked to donate the blood and the tissue, think that this is for the future, and this is for the people that can become patients in the next future.
Absolutely. And from the patient perspective, just to add that you are in control as the patient, and you can stop at any time. And as someone currently enrolled in a clinical trial, I will tell you that I get more care and more surveillance and more interaction with my healthcare team while being on a clinical trial. So Cami, let's bring Cami back online. And if a patient, a newly diagnosed patient, is interested in learning about clinical trials, do they talk with their doctor? Do they talk with Dr. Garasino? Do they talk to their oncology nurse? Do they go to the website? How do they find out more information about clinical trials?
Generally, the oncologist brings that up, or actually Dr. Donington can as well, because we do have neoadjuvant clinical trials. But yes, the physician definitely brings that up. And as the nurse, I am in the room and available to answer any questions as well. So, but patients, they do inquire about it, and certainly we pre-screen. Dr. Garasino is very good about looking at things and knowing, oh, this patient could be potential for the Hudson trial. And then we also have clinical research coordinators that are in our clinic with us as well to help answer any questions as far as the screening and all the requirements for the visits, because clinical trials do require that patients come quite often. But like you said, that way they get a lot more chances to be with their clinical care team.
I will say that the pandemic did force those of us that design and execute clinical trials, not only within academia, but in the pharmaceutical companies and nationally, to really examine those visits and to really say, oh, does that person need to come to my clinic on my campus, or could I do this by phone, or can labs be drawn at the patient's home? And I think that we will see and are seeing a revolution in that aspect of clinical trials, because I think it really made us have a whole new look at what it meant to come to campus or to clinic every 3 weeks or whatever.
Absolutely, especially when parking is so expensive. I know.
Parking is the new side effect. G1, G2, G3, G4.
Well, okay, so this is all really great stuff. Keep in mind that we are virtual, so there may be a strong chance that people who are not in the Chicago area are listening to this or will access it on the replay. So I want to talk about folks that maybe are being treated not at University of Chicago, not at an academic center, whose doctors will not bring up clinical trials. What is your advice to them? Definitely, I always say get a second opinion, but that's easier said than done without knowing exactly, what the right questions are and where a patient should go. So I would love to ask all of you, what advice would you give a patient who is interested in maybe changing where they're getting their treatment and learning about new treatment options and clinical trials as treatment options?
So I believe that the collaborations with the centers is very important. So I believe that we have to create a network of friends, I would say. So when a treatment, a routine treatment is available close to the house of the patients, I think that this can be a favorite option. And so I think that we don't have to say we will see all the patients here, because this can be hard for the patients. We have to remember that the age of our patients sometimes is more than 70, and maybe it can be a burden also for the families. So I think that we have to think always that we have to do the best for our patients. But if a patient is a potential candidate for the clinical trials, I think that we should create the best environment to help these patients to participate to the clinical trial. And I would add also something else that maybe Jessica is modest, but there are some data saying that also the quality of the surgery is very important. So I would suggest to the patients to go only for the surgery in centers with a high volume, because where there are high volume, there is the guarantee of a high quality, and where is a high quality, there is also a longer overall survival. So I would recommend to stay in the academic centers for the surgery, for the multidisciplinary discussion, as we said many times before, and in particular for the clinical trials. And I think that for the other part, we should just use our phone to speak with the other doctors in the area and to find the best plan for our patients.
I'd like to add, oh, sorry, go ahead.
No, sorry, Ivy. I just want to say that, it's really challenging. And unfortunately or unfortunately, cancer care tends to really be clumped in our cities and our urban areas, and it's much fewer once you leave those. You can look for NCI designated cancer centers as a real mark for an institution which should have strength in all of the phases of lung cancer care. And there is a real push-pull between being treated close to home and going to get the best care in the country. And that's really, I think, I agree, very, very hard. I do think it's worth a second opinion. This is a real disease. It's not one to be taken lightly. And I get it. If you have to travel 100 miles to get to, a cancer center, that's tough. But your insurance will pay for a second opinion. And that second opinion, if it matches what you're doing, I love second opinions where I say, oh my goodness, I know that person. They're a fabulous doctor. And this plan makes perfect sense. I love that second opinion. I love knowing where my strong practitioners are in the community and how I can rely on them. And we love that interaction. And for other people, we say, hey, we've got something else, and I think you're perfect. But it also brings up the fact that not every patient is a trial candidate, and there is really good care out there. But I think this lung cancer is, in the United States right now, worth a second opinion. I really do.
Yeah, I think so. It's so difficult now to have the diagnosis and also how to continue, for example, with target therapies when you have a resistance. We have in few years, we have 9 targets. And I can tell you that I work all the day on lung cancer and I read all the day papers, and I have always the feeling that maybe I missed something. So I truly believe that I agree in 2021, a second opinion is very important. Also just to be reassured that you are doing what you need.
And I'd like to add that, newly diagnosed patients may not even know where to go for a second opinion, or they may not even know where to go to try to find clinical trials. So I think the best advice is for them to, connect to, a large, international advocacy group like LUNGevity, to connect if you have a specific mutation to one of the, mutation focus groups that I had up on my slide. And, other, advocates and other patients can help recommend places where to go for second opinions, or, talk about trials that other people are participating in the community. I feel like that's, really critical, especially if someone is newly diagnosed, maybe, far away from an academic medical center, but wants to know whether it's really worth it to try to get that second opinion. And there are some doctors who do remote second opinions as well. It was really, a big thing during COVID, but now with some rules, it's not everywhere as possible as it was before, but there are still some doctors who do remote second opinions. So if you can't travel for a reason or another, it might still be possible to get a second opinion. Just want
Really
to throw that out.
excellent point, well. Ivy.
Yes.
So right, remote. I think that all still happens in most medical centers. State lines have become a little funky.
Yeah. Mm-hmm.
But yeah, it's definitely that, again, one of the silver linings of the pandemic was bringing us all into the world of telehealth, and telehealth second opinions are really useful. For some patients, it's very clear just by looking at their pathology and their scans and having a conversation across the screen, what treatment may or may not make sense.
Well, I can attest to that because Dr. Garasino and myself saw a patient that lived in Nashville last week via video. And after speaking to his wife on Friday, originally he was totally against adjuvant chemo, but after having the second opinion with Dr. Garasino, he is definitely considering that. And Dr. Garasino was also able to refer to some other medical oncologists that she works with closely in the Nashville area. I also want to put a plug in, maybe I'm biased, for oncology nurse navigators. I've not only worked at the University of Chicago, but I've worked in the community, Northwest Indiana, Charleston, South Carolina. And, you know, if you're a new patient, you're newly diagnosed, you don't know where to turn, you know, call your local hospital, your local cancer center, and ask, do you have an oncology nurse navigator? They could very possibly have one that specializes in lung. And when I was just recently in Northwest Indiana, as a navigator, I helped patients, you know, look on clinicaltrial.gov. We'd sit down with my computer and we'd both look to see if there was anything for their particular mutation. So I think you know, reach out to the oncology nurse navigators. They really are a great resource.
Absolutely. As an oncology patient navigator myself, we are giant cheerleaders for our patients. So, and we do network with each other. So that's great, great, great piece of advice. Another thing that I want to bring up is clinical trial navigators. We have those at LUNGevity. So if you visit the lungevity.org website, a clinical trial navigator can help you decipher some of that information and put together some questions to talk to your doctor about what may or may not be a good fit for you as well. And with that, I am going to ask each of you to give us one thing, if you can wrap it up in one thing, that gives you hope in terms of either lung cancer treatment, lung cancer advocacy, the lung cancer space in general. What gives you hope before we wrap up with closing remarks today? Would you like to go first?
Yeah, I think that also after today, I think that the hope is that we are all together. So there are so many people working for to increase the quality of life and the life of our patients that are not just the doctors. There are the basic scientists, there are the nurses, the PAs, the social workers. So I think that truly, if we work all together, I think that we can really change the reality of our patients.
Absolutely. Dr. Donington?
I'm going to totally ruin your question. I actually don't think it's one thing. I think it's actually that so many things are happening all together at the same time, with screening, with better surgery, and with just incredibly better medicines than we've ever had before. It's just everything is changing all at once, and it's given us our biggest hope and our biggest voice, and maybe they are the biggest change, and those are our survivors and advocates. There's no one who can plead for research dollars and getting rid of stigma and all the things that lung cancer needs better than survivors, and we have never had them before. Lung cancer. And the fact that they exist and they're strong and they're growing in number every day now has just changed everything about our disease. So they're my greatest hopes. Okay, I had to think my way through it, sorry.
Okay, well, you just stole my answer because I was going to say that there are more and more advocates, and there's even training for advocates, which didn't really exist so much when I was, you know, first going into this space. And everywhere it's being recognized that advocates can participate, you know, in things and even drive research. You know, pharmaceutical companies are involving us more, you know, all of the different, you know, conference groups are involving us more, hospitals, researchers. So, I mean, to me, that's very hopeful because we're the people living with the disease, and, you know, us giving our perspective on what we need and what we want is going to, you know, really hopefully kind of spur everyone on in terms of urgency and encourage everyone to work together.
Absolutely. Cami?
Yes, and my hope is my patients and my families. They really are so important. And I explained to them that we're making lung cancer a chronic disease, just like diabetes or congestive heart failure. So that's my hope, is that lung cancer is a chronic disease.
Absolutely. Absolutely. That's all of my hope. I love it. I love it. On behalf of LUNGevity Foundation and the University of Chicago Medicine, thank you for joining us today. Throughout this program, you've heard about programs and resources local to the Chicago area. And to complement those resources offered in your local communities, people can also get help navigating their lung cancer diagnosis from the LUNGevity website, our lung cancer helpline, and from survivor and caregiver mentors who have been where you are. So our peer-to-peer lifeline support program connects lung cancer patients, survivors, and caregivers to mentors to get and give advice, encouragement, and hope. We have virtual patient Zoom meetups 4 times a week. These are attended by national and international patients. We have multiple private patient and caregiver groups online and provide multiple ways for people to get involved in the fight against lung cancer. We do have online groups for the different oncogene types, as well as those diagnosed with small cell lung cancer. We also have something called Lung Cancer Gateways that we just launched this month during Lung Cancer Awareness Month, which has all of the different gateways of biomarkers. And if you are somebody with EGFR and you land on our website and you go through that gateway, you'll learn about the EGFR resistors. You'll learn about experts in EGFR treatment. And you'll learn about the clinical trials that might be available so that you can take that, so that you can plug in to Ivy's community or a community that suits your lung cancer diagnosis, and you can get questions to talk to your healthcare provider with. When there's not a pandemic, we host multiple in-person events across the country, including a previous one that we did at University of Chicago called a Regional Hope Summit. We educate and support patients, nurse navigators at the community level, and I just can't wait until we can be in person again. Anyone with lungs can get lung cancer, and we want patients and families to know that they don't have to go through it alone. Please visit lungevity.org, call our helpline to get connected, keep safe, and we look forward to seeing you in person soon. Thank you very much.